of the topics that I should tackle was to give an argument why we should aim for partial repair and especially tendon transfers instead of spacing concepts. So to begin, I want to show that I have no disclosures related to the content of this talk. And then I would like to show you the options for irreparable cuff tears in the young. So obviously in the older patients, you might opt for a reverse, but in the young, a reverse needs to be avoided, at least to a certain extent of age. So the option, the primary option that we have is obviously partial reconstruction, which is still considered the gold standard for irreparable cuff tears in the young. And then recently, many different additions have been proposed to add to partial reconstructions, as for example, graft interpositions, tendon transfers, SCR, balloons, mere debridement, or some work with the biceps that can be extended between the glenoid and the humeral head. So if we now think about this a little bit more biomechanically, we can separate these different concepts into pain addressing concepts, passive stabilizers, and active stabilizers. So for example, if you do some biceps work, just tenotomize it or tenodese it, or you do a debridement, this is addressing pain mostly. It doesn't have a true biomechanical effect. Then if you think about the balloon or the SCR, this is thought to be a passive stabilizer of the humeral head. And if you think about concepts like, for example, the partial reconstruction itself or graft interpositions or tendon transfers, this is believed to be active stabilizers of the glenohumeral joint. So why is stability so important? The problem with irreparable cuff tears is instability. You can see here a superior dislocation of the shoulder during elevation of the arm with this gentleman who has a failed posterior superior cuff repair. You can clearly see the anchors in the humeral head and how the humeral head translates superiorly and actually subluxates superiorly because the center of rotation is not stable anymore. So what has been proposed in the past is, for example, the suprachromial spacer or balloon in space. And this has been a concept that has been applied X thousand times around the globe. And recently there was this publication coming from Andrew Metcalf that showed if you have an irreparable cuff tear situation and you do a debridement versus a debridement plus a balloon, it actually does not give you any clinical benefit. So it seems to be that the balloon concept from a clinical perspective does not work as we would like it to work. Let's look at the SCR. The SCR has been proposed by Mihata already now 10 years ago. So it's not new anymore. We've gathered quite some data over the last 10 years on this. So let's look at it from a biomechanical perspective. This was a study done by a former colleague of mine, Luca Lacchetta. He, together with Peter Millett, they did a biomechanical study where they analyzed how the SCR affects glenohumeral translations. And this is quite interesting. If you look at the dark blue line, you can see the native superior translation during the different elevation levels of the arm. And if you now do a cut of the supraspinatus, so you just take it down, you obviously get more superior translation. And now if you cut the infraspinatus, it translates superiorly even a little bit more. And if you now do a SCR, you can see it improves a little, but it certainly does not bring you back to the native state in terms of stabilizing the center of rotation. So how does it look clinically for the SCR? Does it do better than a balloon? So if you look at the outcome data by Lacchetta and Millett published in Arthroscopy, you can see a nice improvement of all the scores over the course of 2 years. However, if we are honest, this is true for all the techniques that have been published in the past for irreparable tears. It seems to be, it doesn't really matter what you do. You can do whatever you want with the irreparable tear. And as long as you do something, they will get a little bit of improvement on the outcome scores. And as a matter of fact, if you look at this study more closely and you divide the groups between an intact SCR after 2 years and non-healed SCR, so retorn SCRs after 2 years, there is no statistically significant difference between the both groups. So one might say it's doubtful whether the SCR truly has a biomechanical effect, if it doesn't matter whether it tears or does not tear. A colleague of mine, Stefan Greiner from Germany, he did a comparison of SCR versus partial repair. And what he saw is that he couldn't find any statistically significant difference between the gold standard, which is still the partial repair, and the superior capsular reconstruction. So actually also this concept does not seem to provide any benefits from the existing techniques, and it certainly adds time to the surgery and costs, which is an important factor as well. So obviously, I'm not going to talk about irreparable rotator cuff tears without mentioning Christian Gerber. I think he's the godfather of rotator cuff tears, and he has published two very nice studies that I would like to discuss with you guys. So he did a very nice experiment in vivo, so living patients or just humans, where he did a suprascapularis nerve block, and they actually controlled that this nerve block was complete, so that the supra and infraspinatus was not working anymore. And then he looked at the active glenohumeral translations. And what he found is quite interesting. He saw that if you deactivate the posterior superior cuff, this does not lead to superior translation of the head. And the conclusion in this study was that a deactivated posterior superior cuff acts as suprachromal spacer, because even if it's not active, the humeral head does not translate upwards. So it must be a spacing concept. That's what he saw. But he's a thorough guy, and he did follow up with another study. He did the exact same thing. So he blocked the posterior superior cuff with the suprascapularis nerve block, and now he measured the suprachromal pressure, because if this was a spacer, then obviously the suprachromal pressure would need to go up, right? Because if it's a spacer, it needs to take up some pressure. However, it did not. And this means if you have no increased suprachromal pressure when the posterior superior cuff is deactivated, it means that it's not the spacing effect of the cuff that is keeping the head centered. So if this is true, and we obviously believe this to be true, what can be the reason? So let's dive into the topic of muscle strength and muscle balance. You can see this gentleman, irreparable posterior superior cuff tear. He cannot lift his arm, pseudoparalytic. However, if he changes the flexion degree of his elbow and reduces the load of the arm, just by reducing the lever arm, he's able to lift the arm without a problem. So it must be a problem of muscle strength, balance, and loads as well. So what we did is we did a study where we examined the effect of the loss of active and passive function of the posterior superior rotator cuff on the muscle loads of the deltoid and the remaining cuff muscles. And we had a hypothesis that deactivation and resection of the posterior superior cuff leads to an increase in loads compared to the intact and active states in the other muscles in the shoulder. And we also hypothesized that the resection would lead to even higher compensatory loads than the mere deactivation. So we had this shoulder simulator. This was done with the help of colleagues in the US who had this very nice shoulder simulator. We had 7 human cadaveric shoulders, and the elevation was done in the scapular plane with 12 muscle actuators. And we had 3 testing conditions. We had the intact and active cuff. We had the intact but deactivated cuff, so it was intact completely, but there was no loads pulling on it. And then we resected the cuff. And what we found is quite interesting, that it does not matter whether you deactivate or completely resect the posterior superior cuff. There is no significant difference in necessary force produced by the deltoid muscle in the anterior, middle, and posterior portion in order to elevate the arm. It's increased in both scenarios compared to the native state, but it's the same for both scenarios. And the same was also true for the teres minor, and mostly true for the subscapularis, especially at higher elevation angles. So what does this mean? The deactivation and resection of the posterior superior cuff lead to a significant increase of the compensatory muscle loads during elevation. So our hypothesis number 1 was approved. However, there was no significant difference in compensatory muscle load to elevate the arm between deactivated and resected cuff. And what does this mean in clinical practice? This means that 1, the loss of active function of the posterior superior cuff leads to compensatory loads of cuff and deltoid. And it means at the same time that the presence of the passive effect of the posterior superior cuff and capsule as potential suprachromal spacer does not seem to be the main problem that we are facing. And clinically, this supports the concept of partial repairs and active concepts, as for example, tendon transfers over the concepts of spacing concepts like a balloon, for example, or SCR. So this is only biomechanics, obviously, but at least this points in a clear direction. So what can we do in order to reconstruct irreparable posterior superior cuff tears and add an active component to it. So one concept that we proposed in the past, and there are several other concepts out there, what you can do, you can actually extend the irreparable cuff tear, because not rarely if you operate on a young gentleman, for example, big muscular guy, but he has a huge rotator cuff tear with a large retraction, you can see very nice muscle quality still, despite the cuff being retracted PUT grade 3. And in these cases, what I like to do is I just extend the remainder of the cuff with the biceps interposition and fix it to the humeral head. So I extend it similar to a distal biceps repair in a chronic setting where you're not able to achieve the full extension to the tuberosity of the radius. Then another option is obviously if you have no muscles anymore, a lower trapezius transfer, which can be done arthroscopically. And if I was not mistaken, I only saw the last minutes of the live surgery. I just saw this right now, if I'm not mistaken, but please correct me if I'm wrong. This is also a very nice concept, obviously. And then what do you do for superior irreparable cuff tears? This is a concept that I will explain in my next talk a little bit more closely. So I'm going to jump over this middle trapezius at the moment. And now let's stay critical and look at the literature for all the different options that have been proposed. And if we are honest and look at them, we can see that whatever you do, it actually leads to a similar outcome. You can do partial repairs, you can do deltoid flaps, muscle transfers, interpositions, and so on. And even physical therapy is right in there. The effect that you create is quite similar. So as long as everybody of us keeps publishing their own results of their own technique, it will always show this is a nice technique, this is a nice technique, and the other one is a nice technique as well. What we really need is nice comparative studies, randomized trials, but obviously it's difficult because patients, at least in Europe, are not that frequent. And so it's difficult to set up a high quality study. But this is what we actually need. If you look at this outcome, the only good thing about this slide is that it seems that we are helping the patient regardless of what we are doing, but we certainly do not know what the best treatment option is. And then I would like to share some final slides with you, which I like very much, because if you look at this gentleman, then actually you think about it a little bit differently and you think like, what are we even doing with all of our surgeries? And now this is a fairly well-trained older gentleman. You can clearly see on the X-ray, doesn't look too good. This is a cuff arthropathy. There's some osteophytes already. There's clear static superior migration of the head. On the MRI, you can see anterior, superior, and posterior. There is no muscles there anymore. So this is a global cuff there. And what you can see clinically, without any surgery, nothing at all, this is just how it showed up in the office. He moves excellent in all directions. And so if this is the case, and if this can work, maybe we should try to work on this a little bit more in the future without surgery. So this is an example of an elderly gentleman who came to see me in my office. And he said, well, my family knows me as the grandfather who has a paralytic arm. He was known for that for years, right? And you can see how he's trying to elevate his arm. He's just not able to because he has a pseudoparalysis because of an irreparable cuff tear. And this was true for several months and even years going on. And then after 1 week of training with the electrical muscle stimulator that we call the shoulder pacemaker, you can see the patient with a little bit of swing in there is able to lift his arm for the first time since several months. And this can be trained over the course of several weeks, and you get a patient with a much improved function without any surgical intervention. So you can see also the non-operative intervention can lead to these very nice videos that reverse pseudoparalysis that has been shown for SCR or balloons in the past. And then another option is this gentleman. He shows us this concept very nicely. He has a cuff arthropathy on both sides, quite similarly, I would say. But interestingly, if you look at him clinically, you can see that the right arm goes up easily and the left arm doesn't do anything, has a true pseudoparalysis there, even though the pathomorphology looks very similar between both sides. And why is this the case? Because this gentleman had a tumor and had a neck dissection and they injured his accessory nerve. So he's a drooping scapula on the left side and he has a functional scapula on the right side. And you can clearly see with a functional scapula on the right side, arm moves well. And on the left side with a non-functional scapula, doesn't move at all, it's pseudoparalytic, even though he has the same glenohumeral conditions. So in summary, partial repairs, at least in my opinion, remain the gold standard based on the data that is available right now. There's no clear advantage of additive procedures, but in theory, active principles have a better potential to restore the balance of the joint. This is theory. This has not been proven clinically. And what is very important, in my opinion, is that some important factors are not yet fully understood, as, for example, the bony anatomy and also scapular kinematics. So I'm happy to discuss, and thank you very much for your attention.
Thank you, Philipp. Excellent. We've been asked that you continue a second talk. We'll take both the questions related to each other then.
All right. Let me just pull up the slides. 1 second. 1 second, guys. Could you please again confirm that you see my slides?
Yes, confirm.
So I'm going to talk about the so-called middle trapezius transfer. This is at the experimental stage right now, so I don't want to push the concept too much, but I just want to give us some topic to discuss what might be the outlook in the future in terms of increasing our options of tendon transfers. So again, also for this talk, I have no relevant conflicts of interest. So what are the options for irreparable rotator cuff tears in terms of tendon transfer options? We obviously have posterior superior cuff tears where we can do a latissimus dorsi transfer, which is very classical Christian Gerber style. And then we have Bassem El Hassan, who introduced the lower trapezius transfer, which I personally prefer over the latissimus dorsi transfer. Then for anterior superior, we have the pectoralis major tendon transfer, which I'm going to talk about in my last talk. And then we have the alternative options of the latissimus dorsi for the anterior superior tear, and we have the pectoralis minor for, let's call it, not complete anterior superior rotator cuff tears. But in many cases, at least my experience, and please correct me if in India it's different, I'm able to repair maybe the subscap, which only had a partial tear, and I'm able to repair the infraspinatus, and then I'm left with a big gap of the supraspinatus. I'm not able to repair that. This is a very frequent scenario in my clinical practice, at least. And so I was always wondering, what can I do to cover that hole up there if I don't like the SCR and if I don't like the balloon, as I've explained previously, because of this biomechanical consideration? What can I do to add an active concept there? And so let's dive into anatomy a little bit. So this is the trapezius muscle. This is actually the lower part of the trapezius muscle. It extends typically from T3, thoracic vertebra 3, to thoracic vertebra 10. Obviously, there's some variation there. And it attaches to the medial third of the spina scapula. And then you can see this aponeurosis, and this aponeurosis defines the middle trapezius. It runs from about C5 to T3, and it attaches to the lateral 2/3 of the spina and the acromion and runs right behind the AC joint. And then above that, you can find the superior trapezius. And this is also an anatomical structure that starts from the spine and the occipital protuberance of the head. So what can we do with this middle trapezius? Because the lower trapezius you can obviously use for repairing irreparable external rotator cuff tears. And if you have the middle trapezius, you can imagine how you could use the middle trapezius in order to repair irreparable isolated superior rotator cuff tear. And this has been done in the past, but only in the past it has been done with the osteotomy of the acromion and transposition of the acromion down to the humeral shaft. What we tried in the lab and then also clinically is to harvest a portion of the middle trapezius. You can see with the yellow marked cord, you can see the middle trapezius harvested tendon. And below that, you can see the supraspinatus trajectory. And then what we do is we just pass the middle trapezius underneath the acromion and attach it to the previous insertion site of the supraspinatus at the footprint. What you can see marked with the spinal needle is actually the position of the neurovascular structure. So you don't want to release beyond this point. This was just a major dissection in order to display this a little bit more nicely. Here's a video with the osteotomy just to make it more clear. Obviously, in clinical practice, no osteotomy should be done, but just to make it clear how the transfer is achieved. So I would like to show how this can work in reality. This is a failed rotator cuff repair in a middle-aged gentleman. I think in this case, we can nicely obtain a balanced reconstruction of the subscapularis and infraspinatus. However, with the supraspinatus, unfortunately, there was not much chance there to repair it. And so I opted in this particular case for this middle trapezius tendon transfer. You can see the atrophy of the muscle, and now you can see the setting. This is a beach chair position. And to do a diagnostic arthroscopy, you can see the subscap hidden right there behind the scar tissue. You can see some remnants of the previous rotator cuff repair, and you can obviously see the big hole. First of all, remove all the previous sutures. I tend to leave the anchors in there before I create too big of a hole in the footprint area if they are not proud. And then I try to reduce in all direction, because obviously if I can achieve a reconstruction, then actually I do go for a reconstruction, obviously. Then you do the repair of the infraspinatus first. And if you are able to achieve that already, then likely you will get a good result and you did your job already. Everything else, as we saw before, is additional. I like to do some Mason-Allen modified stitches. And then I go ahead and release the tissue right underneath the AC joint. And you can see here now the drawing where my axis will be. So this cut is behind the AC joint. And you can see, if you do this little incision, the fibers of the middle trapezius tendon. And what I do is I superiorly detach it from the acromion, because the tendon is not very long and I cannot go very far medial, because the neurovascular structures will come up at some point. And I will talk about this in a second. Once I have mobilized this tendon, it has about the thickness, I would say, of the latissimus dorsi. You can arm this with sutures and then quite easily pass this tendon inside the joint by using a clamp, very similar to the lower trapezius tendon transfer. And you can pull it inside the joint. You can see here in a minute how the sutures are passed underneath. And now obviously you have to create some portals in order to have a good visibility of the process that you're doing. And then I pull one suture out anterolaterally and one suture posterolaterally, so that I have a nice spread. And I use these anchors that are self-punching and a little bit bigger, so that I get a good purchase on the greater tuberosity that in these revision cases might be quite weak. And then I attach this middle trapezius tendon right in the area where the original supraspinatus would attach. You can notice that in this case, I was not able to cover the entire footprint. So it's a little bit short. And I'm going to talk about this because this is also something that we saw during our our anatomical dissection study. So it seems to be a little bit short. And so this is something that we worry about. Here you can see the intraoperative image from the open mini incision, and you can see the postoperative MRI scan, how the middle trapezius runs into the glenohumeral joint after the transfer. So is there sufficient length? And we always need to be critical. In this case, the length was okay, but not great. I was not too happy about it. And so during this dissection study, what we saw is that this is an interesting concept, because in our surgical simulation on the cadaver, there was sufficient excursion of the middle trapezius without limited range of motion in all cases when the scapula was retracted. Because obviously this muscle comes from the spine. But if you protract the scapula, now all of a sudden the distance gets longer, and now all of a sudden the transfer was not of sufficient length. So this is something that we need to consider. And I believe that in the future we need to interpose for example, Achilles tendon graft, as we do for the lower trapezius tendon transfer. It depends on the patient's anatomy, but I think it will not be long enough in many cases if the scapula goes in a protracted stadium. So what we also need to consider is obviously the distance from the acromion to the neurovascular bundle. We had before the transfer an average of about 6.3 centimeters, and what is more important, a minimum of 4 centimeters. So you should not go beyond the 3 centimeter mark for release of this muscle. And after the transfer, we had a distance of about 4 centimeters with a minimum of 2.5 centimeters. And the transposition was about 2 centimeters for the neurovascular bundle to the lateral side, which seems to be okay without putting any stress on it. So to conclude, the middle trapezius is yet in an experimental stage, but might be an option in the future to cover the whole superiorly for isolated irreparable superior cuff tears, where you're able to partially reconstruct in, for example, the subscapularis and the infraspinatus. However, I believe that a tendon interposition in terms of Achilles might be necessary in the future, as the length might not be sufficient depending on the scapular position. Thank you very much.